So today's topic is bloodborne diseases. So most bloodborne pathogens are transmitted by insect vectors, but I'm very happy to talk about any infections that happen in the bloodstream that aren't necessarily transmitted by insects. So things like FIV and FELV, I think we could probably say are fair game for bloodborne pathogens. So please feel free to jump in and ask questions about whatever you want to talk about, basically. Has anybody got anything they want to cover?
Everything in general and nothing in particular.
Me too. It's actually my birthday, and I'm very distracted because I've been socializing all morning. So, so yes, let's keep it pretty casual today. So let's talk. I want to really kind of keep a focus on the stuff that is clinically applicable to us in Australia, because most of the textbooks are written in the US or reference pathogens that aren't a problem for us. Although, we sort of thought Ehrlichia wasn't a problem for us, and it's now not. It's now kind of endemic in the north end of Australia. So, as of 2020, when it was first reported, so that's a fairly recent evolution in I guess a disease that was exotic and is now like just part of not reportable anymore. It's just part of our clinical kind of things that we deal with now. So why don't we start talking about Ehrlichia or like bacterial, let's say it's bacterial bloodborne diseases. Has anyone ever seen Ehrlichia?
Sorry, anyone ever seen?
Ehrlichia?
No,
Ehrlichia?
I haven't.
No. So Ehrlichia is a bacteria, so it falls under the rickettsial form of bacteria, and it's one that essentially is associated with kind of three phases of infection. So the first, the acute phase, fever, lethargy, diffuse lymphadenopathy, thrombocytopenia. So kind of they present septic essentially. Then there's a really long phase of subclinical infection where they're not symptomatic at all. So that can be up to years long. But they will test positive on a PCR during that time. So they've still got organisms in circulation, but they aren't showing any signs. And those organisms are disrupting bone marrow over that time. So the chronic phase is where they present with pancytopenias, thrombocytopenia, chronic weight loss, epistaxis, stuff like that. Do you know what the vector is for Ehrlichia?
It's a tick, I think.
Tick, yeah, good. Brown dog tick.
Leukocephalus sanguineus, is that it?
Yes, exactly right. Yeah. So widespread disease in the tropics, but yeah, now endemic in northern Australia. So I have actually seen a case of Ehrlichia. We had a puppy that had been acquired from a rescue, but unknown location of origin. And I think it was about 4 months old, very lean, very kind of presented quite acutely, but looking at body condition and stuff, it obviously had been unwell for a while. And pyrexic, neutrophilic, not neutropenic, so it wasn't in that chronic phase where there's no bone marrow, but did have a thrombocytopenia. And on ultrasound had really distinctive splenic nodules, actually. And so when we kind of looked at everything on balance, this is it was when Ehrlichia was first reported as well. So it was actually kind of a weird thing to be testing for in Sydney. I'm just going to see if I can find a picture of the spleen. So there's a good review paper here that might have a picky in it. Sorry. Boring. I bet nobody's listening to this as a podcast. Yeah, you can't. There's a picture in a paper. So if you just Google Ehrlichia, if you're kind of suspicious, if you've got a young dog or you've got a dog that's been in Northern Australia and you're sort of thinking, oh, this is a weird kind of systemic sepsis sort of picture, and you do an ultrasound, just Google ultrasound spleen Ehrlichia, and there's pictures and a really nice review article actually available. So how do you think we diagnose it?
Well, you mentioned PCR
Mhm.
in the early stages. In the later stages, I actually don't know, but I'm wondering about antibody testing. Oh, and also it's you'd see the organisms on a blood smear, wouldn't you?
Yes, good. They live in the monocytes. They're called morulae in monocytes. I don't really know what that means, but let's see if there's a picture in my paper. Ehrlichia cytology. Oh yeah, good one. Okay, let me share my screen. Hi, Simone. Okay, can you see this monocyte? So just on a blood smear, we've got a couple of monocytes here, but this one's got a morulae in it. So if you're suspicious, blood smear and search far and wide. I'm not sure how prolific they are. Have you ever seen it, Simone? Ehrlichia? No.
No, I've tested for it a few times, but I've never seen it.
Yeah.
But I've only worked in Melbourne, so.
Well, I was going to say you're in the wrong end of Australia.
Yeah.
Yeah. So most of these rickettsial diseases are really reported in kind of community dogs. The way that we live with our dogs in most urban centres just isn't really conducive to transmission of it. But because we've got rescue dogs kind of coming from everywhere and a trend towards getting dogs from rescue agencies rather than pet shops and stuff, we are going to be seeing a little bit more of it. Should be on the radar.
Just going back to that blood smear, it looked to me as though that was more like the van neutrophil than a monocyte.
Let me share again. So if that was a neutrophil, I would say that would be a very toxic neutrophil. So this is a neutrophil, much smaller.
No, yeah, okay. It's a neutrophil alongside it.
Yeah, exactly right.
And
yeah.
what the arrow's pointing at is what?
So this little purple dot within the cytoplasm of that monocyte is called a morulae, which is the organism living in the macrophage.
Yeah, okay. So that's quite an unusual nucleus for a monocyte, though, isn't it?
That's a monocyte. That's a monocyte. They're really variable in their nuclear.
Okay. I had a picture of it being a more rounded nucleus. No, okay. I've learned something.
Yeah, and particularly a macrophage that's doing, or a monocyte that's doing something, so reactive, they get this foamy cytoplasm. So yeah, that cytoplasm just looks like there's bubbles in it. Can you see that?
Yeah.
Probably not zoomed in enough for you to see it well, but.
So to the upper left of that nucleus, there's a sort of a ring of something. What are we looking at there?
This one?
Yeah.
That's a neutrophil, but he's got a segmented nucleus.
Okay. It really is segmented.
It really is. So hypersegmented is something that happens if neutrophils are kind of staying in circulation for too long, or I think they can get hypersegmented as part of a toxic change. Correct me if I'm wrong.
I think so.
And hypersegmented is more than 7 or more segments. So we're sitting at 6 here. So they can actually get even busier looking than that. Okay, so you were exactly right, Jeff, in that testing for Ehrlichia can be via antibody, but you kind of want them to be you can't be in the first week of the infection because they won't have developed the antibodies yet.
No.
So PCR is going to be more diagnostic earlier, And then serology is going to be more diagnostic later on.
Later, yeah.
Yeah.
And at what stage are we going to see the organism on the blood smear? All the way through?
That's a good question. I would be very surprised if there's enough organisms in the subclinical phase, which is months and months long, to be detectable, but I might be wrong. I don't actually know how this behaves in terms of evading the immune system for that phase. Has anybody studied this specifically?
Not really.
I'm not really sure. So often these guys get a like thrombocytopenia. They often present with epistaxis or bleeding. And there's kind of two components. They get a hyperglobulinemia as well. And because of this chronic infection within the bloodstream, they're more likely to get immune-mediated diseases as well. So if you've got an organism living in the bloodstream, then you start to get very appropriate immune-mediated targeting of the cells that contain that organism. And anytime we've got increased reactivity of the immune system can become cross-reactive to itself. So in some of these cases, we actually need to use prednisolone. But you want to have checked first, right? Like you've got a dog that's coming with profound thrombocytopenia, pyrexia, really looks like a dog. Oh, that's weird. Yeah, so sometimes we do have to use corticosteroids in these guys, and all of the kind of, you would meet the criteria to say that this dog had immune-mediated thrombocytopenia. It's just that it's probably going to be a weird age for that would probably ring your alarm bells and maybe prompt testing. But that might warrant some doxycycline concurrent with your corticosteroids if you had any concerns. What's another organism that is transmitted the same way that we might see thrombocytopenia in?
I'm just wondering about Babesia canis. I don't know. And also Lyme disease. No. I don't know.
So Babesia, let's talk about Babesia separately because it's interesting and it is transmitted by ticks in most cases as well. But I've got that under my Protozoal category. So I want to just knock over the bacterial ones so that we've got a system to think about it.
Bartonella.
Oh, that's a good one. Yeah.
I don't know.
Not traditionally thrombocytopenia, but could be
No.
because we do get weird immune-mediated stuff with Bartonella as well.
Okay.
It's another, I think it's a rickettsial organism.
Yeah, I'm sure there's another one there. It won't come to the front of the brain, but it's American, but I didn't think we had it here.
Oh, you might be thinking of salmon poisoning. What's that called? It's another rickettsial one. I can't remember. The one I'm thinking of is Anaplasma.
Oh, okay. Marginale.
Yeah, Anaplasma phagocytophilum or platypus.
Okay.
But these ones are endemic in Northern Australia. Platypus is endemic in Northern Australia as well. So there's something that we could potentially see. And this organism likes to live in platelets. We'll see those muralae in the platelets rather than in the monocytes. So we actually get a very appropriate immune-mediated thrombocytopenia. Interestingly, the thrombocytopenia is cyclic because of the way that those organisms replicate and trigger immune activity. So every 10 to 14 days, there's a cycle of thrombocytopenia, which is just interesting. Often, this only causes quite a mild disease. It's not as pathogenic as the Ehrlichia is. And often they kind of fly under the radar and just have some petechiation, bleed when you do a surgery. It's often subclinical.
It doesn't have like that kind of end stage like Ehrlichia does.
No, yeah, they don't have, it doesn't go into the bone marrow and just knock over all of the cells. So we don't see the pancytopenia. It's really just platelets it bothers with. Good prognosis, 4 weeks of doxycycline, same as for Ehrlichia, actually. And they don't get the same kind of profound hyperglobulinemia or an immune kind of response with this one as well. It's just not quite as inflammatory. Okay, what about, let's talk about Bartonella because somebody mentioned it. I can't remember which of you. What's the vector for Bartonella? How is it transmitted?
I mean, I think it's an insect, isn't it? An insect?
It is. Yep.
But not a tick?
Nope.
Fleas, isn't it?
It's fleas. Exactly right. Yeah. So what is the relevance of Bartonella to human health, to public health?
Oh, cat scratch fever.
Scratch fever, exactly right. Yeah. So they think that certain species can be transmitted by ticks, but certainly not the ones that we deal with most commonly. So Bartonella got a lot of publicity right around my exam time. There was somebody doing like a lecture circuit on Bartonella and how much of a big problem it is because we'd only just learned how to test for it. Because previously we'd just not been able to grow it in a lab. We'd not been able to detect it on a PCR because the organism numbers are so low. So now then as we started testing, we started thinking, oh my gosh, it's everywhere. But then it wasn't necessarily associated with any pathology when it was everywhere. So the clinical significance is a little bit kind of iffy. It's not a super inflammatory organism. It's not going to cause pyrexia necessarily. It's not going to cause pus or like really kind of localized infection. What clinical signs might we see with it?
In humans or in
dogs and cats. Let's talk about dogs and cats.
I think I know more about what you see in humans.
Oh yeah. So, okay, tell us, because it is a public health risk, right? So it's worth knowing about. What does it cause in humans?
I think it's you get a nodule at the side of and then it's a very slow thing, like could be anything up to months later, I think. And just toxic signs, really.
Yep.
So yeah, actually, my knowledge is not as good as I thought it was.
So often you do get a local reaction, often a local lymphadenomegaly.
Oh, that's right. Yeah.
And people do get quite sick for the 2 days to a week after they contract it. But then similar to the Ehrlichia, it goes into this chronic phase where it just kind of causes multiple problems, multiple places, depending on where it happens to land in the body. So it can cause the endocarditis, similar in dogs and humans, actually. Cats are fairly subclinical most of the time. But endocarditis, discovasculitis, just granulomatous inflammation in places, just kind of the body's just constantly responding, and polyarthropathies, mostly because of the anti complex.
It's always on the list. But
yeah. There was a paper at some point, and there seemed to be some association between Bartonella and the meningoencephalopathies of unknown etiology. Like maybe it's one of the contributing causes of inflammation in some cases, but it definitely wasn't. This is the cause of MUE or a specific subtype. It's just like there's inflammation when there's a bacteria present. It's not surprising in a minority of cases. Yeah, but for some reason it seems to get into brains. The blood-brain barrier doesn't do much. So it is hard to test for. Why?
Gee, no idea. Look, you can pick it up in cats on a blood smear.
Yeah, you'd be
Um,
really lucky though. There's not many
Mm.
organisms.
And that's probably why, because there's not many organisms. It doesn't produce much in the way of antibodies or antigen that can be found.
Yeah. Also doesn't it takes 7 days to grow in culture. So at the duration that we culture most of our samples for, we don't catch it. And it's endemic. So in flea endemic regions, it's present in 20 to 40% of cats.
Is that if they tested with PCR?
Oh, such a good question. It must be because it's bacteremia. It's they're detecting bacteremia, so it must be PCR on a blood sample.
I'm just trying to think if it's in some of those PCR panels. I think it
Oh,
might
it
be.
is. Yeah. I think it's in the neuro.
Maybe the anemia one. I don't know.
Yeah, I think you might be right.
Hmm.
Oh yeah, it is. Yeah. I had an IMHA cat who had Bartonella, and I was like, oh, I don't know if they're linked or whether he's got Bartonella because I immunosuppressed him. But yeah, when there's fleas about, there's Bartonella about, but cats are pretty subclinical. So you might get a positive, and if a dog lives in a cat household, then it's probably exposed, but it may or may not be significant. So you might test positive. It doesn't mean that bacteria is causing the pathology that you're testing for, as opposed to the Anaplasma and Ehrlichia, which are like, these are the cause of the thrombocytopenia and anemia. So a positive doesn't necessarily say this is the cause, which makes it a bit tricky. As well as the limitations of low numbers of organisms making PCR less sensitive and culture being really slow. And because most animals where there's fleas have been exposed to it, they've all got antibodies. So then serology doesn't really help. So I think we thought it was going to, when I was sort of 10 years ago, when we learned to test for it, we thought, oh my gosh, this is going to explain all of the immune-mediated diseases and unknown pathologies that we've been looking for the infectious organism for, but it's not, I don't think it's as big a deal as we thought it was going to be. Very engaging lecturer, I think, which probably helped with everybody thinking Bartonella was a big deal. What is the most common cause or what common infectious cause of anemia in cats? I'm going to tell you, it's a mycoplasma. Have you come across mycoplasma before, Jeff?
Not sure. No, I cannot be sure. I don't think so. But I mean, doesn't mean you haven't seen it.
No, exactly. So this is a little organism. Mycoplasmas don't have cell walls from memory, and it lives in the red cells. And interestingly, there's a lot of different species, and most of them don't cause any pathology. So you might detect them on a blood smear. You might see them in the red cells on a blood smear. I think that might be the one you were thinking of with Bartonella. But if it's not Mycoplasma haemophilus, that subtype, it's probably not significant. So the where we see it most commonly clinically relevant is that Haemophilus subtype infection in cats with anemia, and often they're immunosuppressed or immunocompromised for some reason. So they're either on medications or they might have FIV or something, and they become quite anemic. It's an immune-mediated anemia, but it's not an autoimmune anemia. So the immune system is very appropriately attacking the red cells which are infected, which results in an anemia. But to manage it, you've got to manage both the infection and the immune-mediated response. So they can become quite dramatically unwell. Dogs are really good at clearing it, so the spleen just clears out the red cells that are infected. But if they don't have a spleen, they're more likely to have a chronic infection, but it's typically not clinical. It's just something that we kind of see or detect on PCR. I might actually show up a picture of what that looks like in a red cell, just in case anybody likes doing their own.
The name Mycoplasma felis comes to mind. Am I suffering acute imaginitis or?
No, so I think they changed the name to Mycoplasma haemophilus.
Okay, yeah.
That's the only difference. Hopefully this picture comes up.
Now, can you see that on the blood smear?
Yeah, I'll show you now. So they're quite distinctive organisms in that they live kind of on the outside of the cell. See how it's kind of almost sitting out. Can you see my screen?
Yeah, I think I might have seen that in America.
Yeah. So obviously if you're looking at this cell from the top, it's going to look like it's inside the organism, but it's interesting, like when you see it on the edge there, it is actually kind of sticking out. So they're called epicentric, we describe it as an epicellular coccoid organism. And how are we going to test for it?
Well, blood smear was one thing.
Yeah, so it's not very sensitive, and it doesn't help us to clarify whether it's the virulent or like very pathogenic strain or whether it's just one of those ones that's not relevant. So typically PCR. So most anemic cats, unless they're very cost constrained, I would recommend doing an anemia PCR panel so that we can test for these infectious causes of anemia. And then that's going to tell us the subtype. Culture's not going to work. They don't like to grow. And any patient that's coming with anemia, what other infectious disease testing are we going to do? Cat.
Cats with anemia, infectious disease. Oh dear.
Viral things that might make them more susceptible to infection.
Oh, FIV.
Yes, yeah, exactly. So anyone that's got an anemia, we're probably going to be testing for FIV and FELV anyway, but even more important because if we then find an infectious cause, we know it's because they're immunosuppressed or immunocompromised, and we know we need to protect them from that in the future as well. All right, so they're the bacterial blood-borne pathogens. Why don't we move on to protozoal? Because have you worked with Babesia? Have you ever worked in South Africa?
No.
No. Have you ever seen Babesia in Australia?
No, I don't think so. I'm just trying to think of whether I've seen it in cattle, but no.
So, really common in South Africa. And it's interesting. I've worked with several South Africans, and they're so good at cytology because they're always like pre-operatively scanning for Babesia to make sure that they're unlikely to have like a surgical complication. So yeah, an interesting perspective given it was so endemic over there. So the relevance to Australia is that it is endemic up in Northern Australia. So we see quite a lot of the subtype Babesia vogeli or something. But what's happened fairly recently is that in Melbourne there was an outbreak of Babesia gibsonia or gibsoni, which is actually not transmitted by ticks, it's transmitted by dog fights and saliva, yeah, and transplacental. But yeah, there was kind of dog fighting ring, and the dogs were giving Babesia to each other, which was an interesting, I guess, turn of events in Melbourne. So kind of opposite end of Australia as well to where we typically see Babesia. So yeah, I'm sure that Simone was not prepared for Babesia in Melbourne. So typically it causes IMHA, thrombocytopenia, fever. The spleen gets quite big. The Vogeli, the one up in northern New South Wales, Northern Territory and stuff, is pretty mild, but the Gibsoni one causes quite profound, severe relapsing clinical signs. And typically they don't show signs for up to 3 weeks after they've been infected, so it can kind of fly under the radar a little bit. PCR for diagnosis. And often these guys, particularly in the Northern Territory, are infected with other organisms as well. So it's important to do a full profile test in these ones just so you don't treat one and miss the other one. And the treatment's actually quite different from like Anaplasma and Ehrlichia and stuff, as well as it's a protozoa. In that we use imidacarb dipropionate for the one in Northern Territory, and the dogfight one, azithromycin and atovaquone combination. All right. What about we talk about heartworm? Because this is something you have actually seen.
Oh, yes.
Yeah. And I think because I work in the city and I've never ever seen heartworm, ever. I've heard about cases, and I've had one of my sonographers did an ultrasound on an echo on a dog and could see the worms in the heart, which I was very jealous of that I didn't get to see it. But yeah, I haven't actually seen it myself. So I am really interested in what you see clinically. What if a dog presented for heartworm, what's the most common way that they would present?
Well, in 2009, I picked up half a dozen cases at Riverston, and of those, one was referred for from another vet for, I think it was just sort of vague illness. I just don't really remember that well, but it might have been referred for a cardiac condition. But most of the ones I picked up were just a questioning thing. Oh, is he on heartworm prevention? Oh, he's not. Okay, how about we test for it?
Yeah.
And asymptomatic. So the only symptomatic, that testing I picked up out of the 6, that was 4 of them. The 5th one was mildly symptomatic. And the other one was the one that was referred, as I said.
Oh, right. Yeah.
Those were the days of diethylcarbamazine. And that was difficult because it had to be given daily.
Yeah.
And I remember one client said, oh, yes, I've been giving it daily religiously. And then one day I went round behind the shed and there they all were.
Oh, cheeky.
In Canberra, saw a couple. There was a bit around the Pialigo Marshes and the Woden Golf Course. And when Cyclone Tracy hit Darwin, of course, a lot of service personnel came down to Canberra and they brought their dogs with them.
Yeah.
There was a dog, I picked it up in a dog in Queanbeyan that had been domiciled with a Darwin dog.
Oh, right. Yeah. And presumably after the cyclone, there would have been mozzies everywhere as well, I would imagine.
Probably. But of course, it'll only transmit if the temperature remains above about 15 centigrade all day and night.
Oh, okay. Interesting. Yeah.
And Canberra doesn't fit that
No, that's
situation.
Yeah.
but like in America, in where I was at Tufts in Massachusetts, in winter it was so cold that the ponds, as they call them, like the lakes, used to freeze over, and they would drive their F-100s out onto the lake and drill a hole and fish through the hole. Yet they had quite a serious heartworm problem.
Is that right?
Because in summer, well, after all the ice had melted, of course, it was very humid and there were a lot of mosquitoes around the lakes.
Yeah, right. And yeah, I guess they just survive through the winter and then start transmitting again, because dogs can be infected for years before they start showing clinical signs, can't they?
Yes, now that's interesting because now what was his name? There's a vet that I had a practice in Canberra who had been in New Guinea, and he said, was it part of New Guinea anyway? He said it was pretty rare to see heartworm that had been in a non-endemic area for more than a year and a half. It was pretty rare to see live heartworms.
Yeah. So the microfilaria, so infection occurs and then it takes 6 to 9 months before there's adult worms there.
Yeah.
The relevance of that is the testing that you're using for heartworm. If you're dependent on adult worm antigen, the infection happened a long time ago. Whereas if you're detecting microfilaria, you'll detect infection earlier.
Yes.
And the significance of that is that if you've got adult worms, so if they're now like 6 to 9 months after having had heartworm treatment, they might have adult worms. And if you then give them a heartworm preventative that might kill the adult worm, what would happen?
I don't know that that's much of a problem with the modern ones. It used to be a serious problem with diethylcarbamazine because 13% would get an acute allergic reaction.
Oh, right, yeah.
So it was absolutely essential that you tested a dog before you put it on diethylcarbamazine. But I think with the modern ones, it doesn't seem to be a problem. But
I definitely recommend testing dogs before you give ProHeart if they've had a lapse in their coverage for that reason, apparently.
Is that, yeah, okay. Because they get embolisms and pulmonary embolism, which can be fatal.
Yes, yeah. So what about cats? What sort of clinical signs might we see in cats that were infected?
I think they're a lot more obscure. But the occurrence, they say for every 10 dogs you see, you might see a cat.
Yeah, I would say much lower.
Yeah.
But then I don't see much of anyone, so.
Look, I'm not sure what the difference is. I don't think I've ever seen it in a cat. You would think, like the Hawkesbury area used to have about a third of dogs not on prevention used to have it. That was back in Tom Lonsdale's day. At that time, it was about a third in Sydney, half in Brisbane, and 100% in Darwin.
Wow. Yeah, that's huge. So cats have much lower worm burdens, which means that antigen tests are less sensitive because there's just less antigen in a cat. And you have to have male and female worms to then have an infection that kind of perpetuates itself, that causes a problem. And we only detect antigen from female worms. So if cats have only got 2 worms and they're both male, but they can definitely cause clinical signs in cats, but we can't detect it by an antigen test. And the most common clinical signs are actually asthma-style symptoms.
Okay.
Yeah, because they get those worms hanging out in the pulmonary arteries, they get inflammation in the pulmonary parenchyma and reactive bronchi as a result of it. So yeah, they definitely get asthma type symptoms. So one of the things on my list in an asthma cat is to test for heartworm. And to test, I would just do a combination of antigen and antibody testing to be confident in a diagnosis. But as I said, I've never seen it.
When you're looking at blood smears, you've got to distinguish the microfilaria from dipetal anemia.
Oh, right.
Uh,
Dipetal anemia.
it's another. Look, I don't know a lot about it, but the microfilaria have a buttonhook tail in dipetal anemia, whereas the heartworm, like the heartworm microfilaria, have a more truncated tail, sort of, and they're a bit shorter and fatter than dipetal anemia, and they move differently as well on the blood smear. If you do a raw, a raw smear, and I've just forgotten now which is very active and which will sort of move in the same place and which one will migrate on the wet smear. One of them does and one of them doesn't, and I've forgotten which it is because it's so long since it was a problem.
But to have microfilaria, there has to be such a, it's a microfilaria on a smear. There has to be like quite a severe infection.
Oh, yeah. In fact, up in Brisbane in the day, they commonly would do just the blood smears and diagnose them that way.
And the echo is interesting. I wish I could remember the patient's name, so we could show the images, but it's a nice way of diagnosing heartworm. So what sort of changes do we see in the heart when there's heartworm present? Where do the heartworms live?
Oh, they live in the pulmonary arteries and in the base. They start in the base of the lungs. So, on the X-rays, truncated and tortuous pulmonary arteries, and probably right-sided enlargement. And you can get, if they're really chocked up, you can get cable syndrome. With it, and the solution is to operate and remove them. And practitioners in the old days used to be quite good at that.
There is I hope I can find a video. It's so cool. There's a fantastic video of someone extracting worms with a red rubber catheter. Hopefully I can find it. So can you actually, while I find this, can you please describe cable syndrome? This is something that we see.
I was scared that you'd ask that because because I actually can't remember, but I would think that you'd probably get
with these, and I want to,
you probably get swelling.
Your signs you're in after 50.
I hope this is sorry, swelling.
I would have thought you'd get signs of venous obstruction to the probably.
We see cable syndrome quite commonly with cranial mediastinal masses. That's by far the most common cause of it in the population that I see. What happens is that you get obstruction of the cava returning blood to the heart, but only obstruction of the cranial cava, not the caudal cava. So the blood's coming back from through the liver and back up from the abdomen just fine and dumping into the right heart, but it can't get back from the cranial aspect. So worms can do the same thing. So if you've got an obstruction to flow in the cranial cava into the heart at any point along there, you get this thing called cable syndrome, and it's just increased hydrostatic pressure in the cranial cava, which results in this like really distinctive edema, like a wobbly, like nana neck kind of thing in dogs, and it's really distinctive appearance, and it makes me go straight away cranial mediastinum or heart. So see what they've done here. They've tied suture material through the red rubber. So it's quite high thickness suture material. They've clamped and got venous access into the jugular. And he's demonstrating there that he's going to pass the red rubber down the jugular, essentially into the heart. Look at that. Ew. How cool is that?
Wow.
Wow.
So he's used hemostats on that. So he's obliterated the vena cava on that side.
No, he's actually just in the jugular. And we know dogs are amazing at recanalizing, and also they've got so many options for diverting blood flow. Like we often cause a thrombosis in a jugular when we take a blood sample. We often we hold off for a long time. Oh, it's amazing. I love this video. Isn't that cool? So we often get occlusion of the jugular. I think most of us have tried to get blood samples from someone at some point and just gone, oh, that's just a big clot. Like animals that have been in hospital for a while and stuff. But dogs are amazing at just rediverting blood flow. I'll stop sharing now because that's probably the only thing that I wanted to everyone to see. Yeah, so there's a resource that I'm not going to go into a huge amount of detail on treatment of heartworm because I don't have any experience in that. But there's a resource online called the American Heartworm Association that has got so much information. It's so valuable when you're studying. So just have a look on there. They've got really, really detailed protocols on diagnosis and life cycle treatment and stuff. And then also summaries, which is very handy when you're in a clinical environment. You just need to get to the point really fast.
Yeah, I lost quite a few dogs that I treated.
Yeah.
And I know, one of the vets that was working for me at the time, I was just so upset because so were the owners at losing a reasonably high proportion of them. And I said to him, what am I doing wrong? And he said, well, nothing. You're doing everything according to the way you should. That it was just the luck of the draw, I suppose.
Yeah.
The treatment that I was using last was I've forgotten the name of the drug, the newer one, not the old. Yeah, not the old arsenic, not the original arsenic one, which you gave 2 doses of. But if you give 1 dose of the new one, I think it's an intramuscular injection. And then is it a month later you give the 2 to finally finish them off?
Yeah.
So
I'd always consult the Heartworm Association guidelines. But the main thing that they say is first dose, then after that, they're not allowed to move. They've got to be in a cage. They can't get excited, get agitated. Why is that?
Oh, because they're more likely to embolize.
Good. Yeah, exactly. So those worms, when they die, they're going to detach from where they're attached to, and they're going to shoot off into the pulmonary artery, and they're going to lodge in the lung. So if all of the worms die at once and all of them shoot off at once when the dog runs around, then he's going to completely obstruct the blood flow to the lungs and get catastrophic right-sided congestive failure. Or actually the heart can stop. So there's it's called a suicide ventricle. If flow out of a ventricle, particularly right ventricle, is blocked suddenly, the heart has this reflex stop, because if it gets over pressure. So if you obstruct the pulmonary artery suddenly, the heart will stop. So that's maybe the cause of sudden death in those patients. Although right-sided failure and obviously failure to be able to oxygenate is going to cause sudden death as well. So yeah, very interesting disease. I hope I never see it. But if someone can do the red rubber catheter trick for me, that would be amazing.
Yeah, I hadn't heard of that one. I'd heard of people putting forceps in and pulling them out, but
Yeah. But then
yeah.
you're grabbing blindly. Like it's such a nice technique. I mean, I don't know what the like stats are on survival and stuff, but it's pretty amazing. Now the only other things that I wanted to cover are viral infections, so FIV and FELV. We do have full chapters, like we've got full sessions on those because there's so much work on them and they are common and detailed. So I don't want to go into too much information now, except for really transmission because they're not vector-borne ones, are they?
No, they're the vector's another cat.
Yeah, exactly. Yeah. So how is FIV transmitted?
That's cat fights and scratches.
Yeah, exactly.
That's saliva.
Yeah, yeah. And it's not actually transmitted vertically, as in, well, it can be, but it's rare, to kittens. So it's usually sort of cat to cat, through fighting. It's everywhere. So up to 20% of cats, outdoor male cats in Australia have it. Lower incidence, obviously, in indoor cats and cats that aren't fighters. And I don't want to go into too much more information on FIV. Let's keep it up our sleeve. What about FELV? What's transmission? Pattern of transmission?
That's a different one. Well, it's not very common in Australia, but we used to see a lot of it in the Northern Hemisphere.
Yeah.
And very little FIV. I can't remember, but I think it's it can be transmitted like sneezing and oral, like respiratory transmit.
It is, yeah. It's actually saliva. So sharing bowls and stuff is a risk. Grooming each other. Bites will transmit it as well. And it can be transmitted vertically. So it can be transmitted via milk, actually.
Yeah.
Yeah. And as you said, much lower prevalence in Australia for whatever reason. And again, can cause all of the anemias and immunosuppression and stuff that we talked about with some of the other blood-borne infections. And associated with leukemia, obviously, that's what it's named for.
Yeah, most of the ones I saw in America were lymphomas, particularly mediastinal.
Yeah.
Because in emergency, I got the ones that were exuding fluid and they'd come in with a sort of a hydrothorax, except it was neoplastic discharge. And you could pick it on the look of it before you even put it under the microscope. It's got a sort of a brownie look about it.
Yeah, interesting.
And you put them on pred for the night and they'd be dry in the morning. Of course, you tap the chest as well, but
never to come back. Well, eventually.
Oh, I wouldn't say that.
Maybe not ever. We're not curing cranial mediastinal lymphoma with fundosupred. Yeah, so we're going to go into much more detail on those two later, but I might actually clock off a tiny bit early and take my son to school for my birthday.
Yeah. Well, happy birthday. I won't ask you how many, but I'm sure you'll be a lot more catching up to me.
I don't care. Yeah, catching up in a hurry. Yeah, all of the passwords on all of our work devices are my birthday so that everyone remembers it, but that means that I can't be shy about how old I am. This is a big joke. We did change it from 1982 to 1992 at one point. If there's a joke. I dropped 10 years, but not too many.
I use the birth date of my grandparents.
Oh, do you? Yeah, right.
Quite often.
Yeah.
And yeah, but not in its normal order. I sort of mix it up.
Yeah.
But I had an interesting experience when we were away cycling. We had a bike lock that had a code on it,
Mm.
And there was someone else there didn't have one, and they said, "I will lock mine up with yours."
Mm.
Because anyway, it turned out that she wanted her bike before she thought she was going to, and it had the bike lock on it, and someone cracked it because it was someone's birthday. So he just started off with the 19s and went through about the right period and got the bike out.
Yeah, it's not a very secure password, that's for sure. There's definitely been people hacking into my phone my entire adult life because that's my password.
Yeah, you need at least, I think it's at least minimum 12
Yeah,
assorted digits.
yeah. One day I'll focus on my cybersecurity, but not today.
Oh, dear, oh dear. Well, just keep checking your bank account.
That's right, exactly. Thanks so much for coming, Jeff. I'll
Yeah, well,
see
thank
in a
you.
couple of weeks.
Yeah, hopefully. Yep.
Yeah. Bye.
Okay.
Bye.
Bye.